Good evening, everyone, and I want to welcome you all to the Pennsylvania chapter's Let's Talk Infection Control in the Time of COVID, presented by our Pennsylvania chapter of the American Academy of Pediatrics. Due to the growing need for up-to-date information around COVID-19, we're now offering a modified version of our Let's Talk webinar series to our members. This series will take place weekly and serve as a community forum for pediatric providers to discuss updates and hear and share clinical challenges and solutions around the management of COVID-19. Our webinars will take place every Wednesday from 8 to 9 p.m. In addition to tonight's webinar, we are also offering a follow-up Q&A session with our presenter, Dr. Meg Fisher. That will occur this Monday, April 13th, from noon to 12:30 for those of you who are unable to participate tonight due to the first night of Passover. My name is Trudy Hecker. I'm Vice President of the chapter and a general pediatrician at the Children's Hospital of Philadelphia. The webinar will be recorded and the webinar link will be emailed to all participants, and it will be available on our website at www.paaap.org. Information on obtaining CMEs and CEUs will be emailed to all our participants following the webinar tonight. Information presented on this webinar is educational in nature and does not necessarily represent the views or policies of the Pennsylvania chapter or of UPMC, who is our accrediting organization. We'll have plenty of time for questions and answers after Dr. Fisher's presentation. If you have questions throughout the webinar, though, you can type them into the comment box at the right-hand side of your webinar screen. We anticipate many questions and hope to have answers for most of them. Instructions on how we'll navigate further through the Q&A portion I'll give after Dr. Fisher's presentation. Needless to say, I'm thrilled to introduce Meg. Dr. Fisher graduated from the Susquehanna University, and her medical degree was from UCLA School of Medicine. She completed her pediatric residency and fellowship in pediatric infectious diseases at St. Christopher's Hospital for Children. Her current appointment is chair and medical director of the Unterberg Children's Hospital at Monmouth Medical Center, and she is a clinical professor of pediatrics at Rutgers RWJ School of Medicine. Dr. Fisher has numerous medical and academic activities. She was the former member of the AAP Red Book Committee. She's a member of the AAP Committee on Continuing Medical Education, has been on the editorial board of PrEP Audio, the executive committee of the AAP section on infectious diseases and disaster preparedness, and as a former officer of the New Jersey chapter of the AAP. She currently serves on the board of directors of the AAP as our District 3 chair. Thank you, Meg. She represented the AAP in the development of many CDC guidelines, including those for smallpox, anthrax, botulism, and Zika virus, and had over 40 articles published in peer-reviewed journals. We're so lucky to have Meg with us tonight, and personally I want to thank you, Meg, because we know each other for many, many years from when you were at St. Christopher's. So to meet this CME requirement, please be advised that Dr. Fisher has no financial disclosures to report. And with that, I'll turn it over to you, Meg. Thank you again.
Thank you, and thanks for that introduction. It's a pleasure to talk to my Pennsylvania friends and to recognize so many of the names of the people who are on this webinar. So thanks. Without further ado, I'm going to just go ahead and get started. So long as I can advance the slides. Yep. So my first slide is, as you can see, is a disclaimer. And I think it's important with so much new information coming out literally every minute. You just have to realize that much of the information you're going to hear tonight will be out of date within hours to days. The two best websites for very much up-to-date information are the CDC website and the World Health Organization website. Also, at the end on my reference slide, the Red Book Online is actually updated pretty much daily with specific information about the novel coronavirus 2019. So as far as disclosures go, as you heard, I have no financial disclosures. I will not mention off-label uses of drugs because I'm not going to talk about treatment, but I will mention I may mention some off-label uses of personal protective equipment. So just a short background before we get into the infection control. So as you're all aware, the coronavirus 2019, now called COVID-19, began in Wuhan City, the Hubei province in China. It appears to be a novel corona strain, and in this case, it seems that the corona strain of the bat and the corona strain of the pangolin got together and made this new virus, which has formally now been called SARS-CoV-2. The pangolin, for those of you who don't know it, is a spiny anteater, and its meat is considered a delicacy in China, and it is also, the spines are used in traditional Chinese medicine. So this is considered an endangered species in China, and it is sold at markets, and it's believed that it probably was in the market in Wuhan City. It was a seafood market which also had some of these endangered species. So that is presumably how the virus evolved. It's also possible that the pangolin wasn't involved and that perhaps this virus came directly from the bats. But whatever, it certainly is here to stay. The World Health Organization declared this a public health emergency in the end of January, and a day later the U.S. declared it a public health emergency. It wasn't until March 11th that the World Health Organization declared this a pandemic. And when you see the figures of how much disease there is throughout the world, you see why it certainly is a pandemic. So this is a global map from the CDC website, and although there's a few countries on this map that are in gray, as if there were no disease there, if we look at other sources, there's disease pretty much everywhere in the world except Antarctica. This is a World Health Organization map, and this one's a little different. This just looks at disease within the last week. And the darker the country, the more disease there is. So you can see the darkest countries are much of Europe and the United States. And now disease in China is much less common. So this is a nice map for showing you where the active cases are. Now if we go to the Hopkins University tracking site, and this is, you can Google this and get onto it very easily. This is a map of the active cases as of today throughout the world. So again, you can see that Europe and the United States are way overrepresented versus the rest of the world. But you can also appreciate that this has disease both in the north and the southern hemisphere. So just because you're in one temperature or another did not spare you. And also, of course, there's disease on the tropics, right at the area of the tropics. This is the cumulative cases in the world since the recording started the beginning of this year. And you can see again, the United States and Europe have really overtaken China as far as cumulative number of cases. So this is from the World Health Organization situational report. And obviously this is a very dense slide, but what I wanted you to get a feel for is the fact that globally there are over 1 million cases and 72,000 deaths so far. But I also wanted you to look at the difference in the fatality rates depending on where you are in the world, with a low in the Americas of 2.9% to a high of 7.7% in Europe. And part of that reason for the higher fatality there is the overwhelming of some of the health systems. So we know or we think that the overall fatality rate is actually going to be far lower than the 5.7% because the only cases that are counted are the ones that are very symptomatic enough to have been diagnosed. So we're missing a lot of the mildly symptomatic people. So likely the case fatality rate is actually lower than what's given. This is cases in the United States. So far we've had 374,000 cases with 12,000 deaths, and that gives you a fatality rate of 3.2%. Cases have been reported from every state and also from the District of Columbia, and then the territories, Puerto Rico, Guam, the Virgin Islands, and Northern Mariana. So this map, which is an interactive map, is on the CDC website, and I've tried to give you the websites on the slides. And these slides hopefully will be available to you from the PA chapter, so you can look these up at your leisure. But if you just hover over the state, it will tell you how many cases have been reported, and if you click on the state, it will actually take you to that state's Department of Health, where you can get more information. So this is from the New York Times, and normally when I'm giving a scientific presentation, I don't quote a magazine or a newspaper rather, but the New York Times has incredible information and really very nice reporting that's updated every day. And these are cases as of today, and you can see most cases in New York, then New Jersey, but Pennsylvania is certainly within that top 10. And what's very nice is if you look on the right-hand side of this slide, look at the colors. So this is the case growth rate. So the darker the color, the faster the case growth rate. And what you see in New York is it's starting to slow down. And this for me in New Jersey, where it's also starting to slow down, is the best news we've had in weeks. And the reason that's such good news is it does appear that we've hit the peak, and perhaps we are bending that curve, and we're going to start to see either no increase or certainly much less of an increase. So it kind of gives me hope that, yes, we are going to get through this before we run out of equipment and staff and everything else. These are also taken from the New York Times, and this is the top graph looks at the United States as a whole, and you can see the total number of cases, and then in the lighter pink, the new cases each day. So again, I think you can see maybe this is beginning to level off, and that's really what we're hoping for. And then I also looked up Pennsylvania, and this is what's happening in Pennsylvania. So you're a little behind some other parts of the country, but again, hopefully you're starting to level off at the top, which would be the best news yet. This is from the Pennsylvania Department of Health, and this shows you county level of cases in Pennsylvania. The green have the least number of cases, the blue a little bit more, the yellow next, and then that kind of orangish color next, or no, I think that it's actually that light color next, then the orange, and finally the pink in the areas where there's most disease. And as you could have guessed, that would be around Philadelphia and around Pittsburgh. So what do we know about this virus? Well, we know that it very efficiently spreads from person to person. And if you've seen some of these information about the R0 information, that's how many people are infected by one person who has the disease. The number for coronavirus is somewhere between 2 and 3. The number for measles is 18. So it's certainly not as transmissible as measles, but it is around or a little bit more transmissible than influenza. And I meant to add that slide, and I'll do that the next time I speak. But you can find slides that show you a comparison of how contagious different viruses are. So we know this one's very efficient in its spread. The incubation period is between 2 and 14 days, with a median between 4 and 5 days. Respiratory spread is the major way that this is spread. And remember, with respiratory spread, it's droplets that we're talking about. So these are droplets that fall to the ground, generally within 3 to 6 feet. And we're going to come back to this, how it's transmitted, when we talk about infection control, because in order to understand how we prevent transmission or how we control the infection, we have to understand a little bit more about the transmission. Unfortunately, we still have lots of unknowns. We don't know how contagious asymptomatic patients are. We do now appreciate that certainly in some cases, and maybe even many cases, asymptomatic or just pre-symptomatic patients are contagious, but we don't know how contagious. Further, we don't know how long a person stays contagious. And finally, we don't know what the role of children is. We know that as far as disease, children are very much underrepresented. So this is a disease of adults, not children. What we don't know, we do know that children are infected by their parents and by their aunts and uncles and adults in their environment, but what we don't know is how much they contribute to the spread of the virus. In SARS and MERS, children were rarely affected, and there was very little evidence that children were a major factor in transmission of disease. So we're hoping that's the same for COVID-19, but we can't be totally sure. All right, so let's get to the infection control. And I've borrowed some of these slides from a talk that was given on an AAP webinar, and actually it was the AAP ECHO session. And these are the things that we think are important for infection control. First of all of your staff need to be educated. They should be able to identify potential cases, and they should know about personal protective equipment and which ones they should wear and when. It would be great if you have visual clues for your patients. So the CDC has a number of things that you can download for free, and these are posters that you can put around your office to inform people about the COVID disease and to tell them symptoms and a variety of other things that they should be aware of. When you're fielding calls from patients, be sure that your staff is aware of what kind of key questions they should ask, because those calls are sort of your way of your first triage of patients that you decide you're going to see either in person or by telehealth, and you really want to think about what questions to ask. So questions such as, have they had contact with anyone who has COVID disease? Have they traveled to areas where COVID is common, such as New York City or New Jersey right now? Do they have any of the suggested symptoms of COVID? And then don't forget, especially if you're planning on having these people come to your office, you need to ask about the parent that's going to bring the child as well as the child. Because if the parent is symptomatic, that's going to put you and your office at risk. So be sure to ask not only is the child symptomatic, but what are the parent's symptoms? And then if it's possible in any way, try to avoid having patients sitting in your waiting room. Some of the things people have done is take out some of the chairs in the waiting room, so if there is anyone there, they have to be seated at least 6 feet away from the other person. Other practices have had people wait in their cars, and then they call them in as soon as a room is available. But what you're trying to do is avoid that contact between patients, since, again, we now think that asymptomatic people may be capable of transmitting the virus. We want to make sure that we're following the Centers for Disease Control guidance on protective equipment. This is a little difficult because some of the recommendations have changed. The most important use of a mask is to put the mask on a patient who has symptoms. So the best use of that mask is to prevent the symptomatic person from spreading their droplets away from their face. It is recommended that N95 masks be used for the care of positive patients, but if N95 masks are not available because of shortages or because you just don't have them, then a procedure mask or surgical mask can be used. However, if you're doing something that's possibly going to aerosolize the virus, then you really do want to have an N95 mask. There's debate as to whether taking the NP culture that you use for diagnosing the virus, whether that is aerosolizing or not. I think that if you use the swabs and do an NP culture properly, the patient does tend to cough, sneeze, etc. So in that case, it probably is aerosolizing, and therefore you should be protected not only by a mask, but also by eye protection. So I think even if you have all the masks you want, when you're doing something that causes an aerosol, you do want to protect your eyes as well. And glasses are not good enough. You really want to have either goggles or a face shield. One of the other things we do in offices that can cause aerosols is using nebulized treatments. So it is recommended that whenever possible you use meter-dose inhalers instead of nebulized treatments for your patients with bronchospasm and asthma. You should strongly consider canceling elective surgeries and procedures, and this is certainly something that's already been done in most states and most hospitals. And then this is one that we don't pay much attention to, but we need to start getting better at this. So we need to require that sick staff stay at home, not come to work, don't tough it out, stay at home. And that's a hard message, I think, for many pediatricians and many of our nurses and our office staff. What other things should we be doing? Well, it's recommended that you screen people who are going to enter healthcare facilities, whether that be your office or whether it be a hospital. And what you're screening for is whether or not the patient knows that they're COVID positive, whether they've had a recent exposure to someone who is COVID positive, what's their temperature, and what are their symptoms. And depending on those things, you may or may not want them to enter your office. So in our hospital, if you were a visitor and you were known positive or you had fever or symptoms, you would not be allowed to visit. And if you were a patient, you would be given a mask and sent to the emergency department. We need to be sure we're communicating with our local and state public health departments and we're aware of what's happening. This is particularly important if any of your physicians or your staff in your offices develop COVID-19 and you're worried that maybe they were working or maybe they exposed your patients. Always try to use your local and state public health departments to help you out in those kind of scenarios. We ask that all practices really prioritize, if you're going to have face-to-face visits, the ones we want you to have are the newborn visits to assess those babies. Remember that many children are now being sent home at as close to 24 hours as possible, so we really want to do that newborn visit, and we want to ensure that children get immunized during this time. We don't know how long this is going to last. And I think anyone who has white hair like I do, we really feel very strongly we don't want to see meningitis come back. So we really want to get those 2, 4, and 6-month immunizations in. And we know we don't have the best control of measles, so we'd really like to get that measles vaccine in as well. And, of course, chickenpox would be a bonus. Whenever possible, you should use telemedicine if you can. And Sue Cressley will tell you how to make sure that you get paid for those televisits. She's recorded information, and I believe it's available on the AAP website. And all of you who know Sue Cressley knows if she tells you how to do it, that's how you should do it. This is a document that literally was, it just came out 2 days ago or 3 days ago. It's from the Centers for Disease Control and Prevention, and it's about specific guidance for ambulatory infection control. So I wanted to go through this document and tell you what their recommendations are. Remember, this is not geared at pediatrics. This is geared at all ambulatory medicine, so urgent cares, physicians' offices, clinics, all of those settings. So the first recommendation is that you delay elective ambulatory provider visits and implement care models such as telemedicine. So for us, this would mean some of our elective visits, we can either do them by telemedicine or delay them a bit. They do, however, say that although they don't care if you maintain adult immunizations, they do say maintain childhood immunizations. And ways that you could safely do this would be to try to schedule morning well visits and afternoon sick visits with the idea of trying to keep the well children away from the sick children so that they could get their vaccines but not get exposed. You could try within the office separating the patients in space. And what some people who have multiple practices have used one site strictly for well visits and the other site for sick visits. Or you could collaborate with someone in your area to try to work out within your community a place for immunizations. I've also heard of at least one practice that's doing kind of drive-by immunizations so that they're actually taking the vaccines out of the office down to the person's car and immunizing them in their car. I don't know that that's practical for all of us. The next thing this guideline says is that we should be exploring alternatives to face-to-face triage and visits for the acutely ill. So they're suggesting using things like telephones and online advice, but they want this to be from healthcare providers. So this does give me a little bit of pause and a little bit of cringe. It's sort of like flies in the face of the medical home unless you're the one giving the advice. So I think as much as possible we want to communicate with our patients and we want to try to keep them out of emergency rooms and out of offices as much as possible, but clearly some of them are going to need more care. The next guidance is to implement algorithms for patients who have symptoms. So the patient calls with symptoms and you try to figure out should they either call 911 right away, should they go to an emergency department, or should they come to your office, or, next bullet down, should they actually stay home. So we need an algorithm for patients who can stay home, and we need to be sure that they understand while they're at home they should be isolating themselves from their family members and also not going out of the house. We need to let them know what kind of home care they would need, and we need to try to make sure that they can check in with a provider, preferably with their medical home, to see how they're doing along the way. It's also recommended that we engage local community organizations and home health services to assist in any way possible. So if there's visiting nurses or some kind of organization that can go into the household to deliver food or medicine or home care, that would be an important item. We should be safely triaging and managing patients with respiratory illness. So again, we want to have those visual alerts for patients. We want to make sure that within any healthcare setting there's adequate hand hygiene supplies. And remember, soap and water is ideal, and hand rubs will work as well, but there's nothing wrong with good old soap and water. We should have available face masks for patients with respiratory symptoms. And this is actually something that's been recommended for a while, but I'm not sure that most offices actually have face masks that they could give their patients. But if possible, this is something that we really should be doing, and it would apply to influenza as well as COVID-19. But for now, we're talking COVID-19. And then do everything possible to reduce crowding in waiting areas. We need to understand the impact and the spread of the illness in your area, and this is where talking to your local health department and listening to accounts or health alerts in your area is really important. There's this thing called crisis standards of care, and this is what we will have to do if we run out of ventilators to take care of people with COVID-19. We sincerely hope that we never get to crisis standards of care, and in most scenarios, this would have to be declared by a government official, such as your governor. Then we also need to know about alternate care facilities. So, for instance, in New Jersey, they're setting up field hospitals. In New York City, you know that they had the boats come. So there are these alternate care facilities. and in some areas they're actually setting up hotels to be places for alternate care. If your office or your healthcare center becomes a screening site for COVID patients, then you need to really be sure that the staff are trained and that they really know how to use the personal protective equipment. We need to monitor providers and ensure that we have sufficient staff in order to keep going. Sick people have to stay home, and we have to know when they're allowed to return to work. We should not be requiring people when they're returning to work to have a note from their healthcare provider. Employees should check for illness prior to coming to work. So, and then you should consider screening people for fever or respiratory symptoms before they enter your office. Again, I'm not sure how practical that is, but certainly people at home can take their temperature, and if they have any degree of fever, they should not be coming to work. And then we need contingency plans if we run out of staff. And finally, you're supposed to optimize your supply of PPE, and that's probably the least practical of all these things, since I know that most of you can't even get PPE. But wherever you can get it, optimize it, and this is where the off-label use comes in. So think of ways to extend the life of your PPE, and those ideas are actually on the CDC website for how to optimize use of PPE. These are the two other considerations they have in this document. We should consider reaching out to patients who have medical comorbidities and potentially other people that are high risk, just to see how they're doing and to see if they need more medications or if there's any kind of instructions, and what should we tell them as to when they should call us back. And then finally, we should eliminate patient penalties for cancellations and missed appointments related to respiratory illnesses, because in that scenario, they're protecting us. So in order to really understand infection control, we have to say, how is this virus transmitted? So there's no question that by far the most common route of transmission is person-to-person contact and it has to be close contact, so up close and personal with a symptomatic patient, and it's spread by respiratory droplets from coughs, sneezes, and talking. So this is the major route of transmission. Everything else plays a lesser role. We don't know exactly how much less. We know that when you're up close personal, the droplets from those people who are coughing or sneezing or talking can sometimes land directly onto your mucous membranes or be inhaled. It's not totally clear how much fomites are involved, but we know that this virus will stay alive on a surface for hours to days, depending on the surface. So certainly if someone has just coughed on a door handle, and you then put your hand on that same handle and pick up some of the virus on your hand and then rub your eyes or pick your nose, you can self-inoculate yourself. But again, the most common method is that direct, close contact, face-to-face with another person. We now know that asymptomatic infected people likely do play a role in transmission, but exactly how big that role is not clear. Likewise, the contribution of aerosols is uncertain. You can aerosolize almost anything, but it's really not clear for this disease how important those aerosols are. And the CDC and the Red Book both say airborne transmission is highly unlikely. The CDC says over a long distance. The Red Book says airborne transmission has not been proven. So what about personal protective equipment? First of all, who needs it? The person who needs it the most, the person who needs a face mask the most, is the person who's got confirmed or possible infection. And what you're trying to do with that face mask is to prevent their droplets from going outside their mouth. So we want their droplets to go onto the mask rather than onto us. And for us, healthcare personnel should adhere to standard and transmission-based precautions And the recommendation for this disease is that you have either a respirator, an N95 respirator, or a procedural or surgical mask. And if there are not respirators available, then a mask is considered appropriate. And eye protection. So this is the one I think probably very few of us have ever used in private practice, but that's either goggles or a face shield. Again, your glasses are not adequate protection. And then a gown and gloves. Of all the things that you're going to have, the gown is the least important and the gloves are the next least important. So it really is that protecting your mucous membranes so that those droplets don't fall directly on you, and also so that you can't rub your eyes and pick your nose. And then hand washing is always important and should always be part of PPE. Now remember that all cases require isolation. So if you're talking to a patient on the phone and you're pretty sure that's what they have, they should be self-isolating at home. We don't, unfortunately, know how long they're contagious. So we've sort of made up these rules for stopping isolation. And these are truly made up. So the first rule is it's made up too. But there are two methods for stopping isolation. The first is if you have tests available, and I will tell you that in New Jersey, testing is still limited, so we wouldn't be using testing to stop isolation except for hospitalized patients. But if you had tests available and they weren't very expensive, you could do a PCR test on a person who's been afebrile for at least 3 days and is at least 7 days after the onset of their symptoms. And if they're negative that day and the next day, then they can stop isolation. The other way, if you don't have testing available, is the person needs to be afebrile without antipyretics for 3 days, and their symptoms should be better, and it must be at least a week from the time their symptoms started. Now, what about return to work for physicians and nurses and other healthcare providers? So it's, again, either the negative PCRs twice or the second one, afebrile for 3 days, symptoms better, at least 7 days since the onset of symptoms, but then we would also have you masked for an additional week. So a total of 2 weeks from the time of symptom onset. I want to spend the next few minutes talking about, and I'm not leaving a lot of time for questions, but I'm going to go through this because I think a lot of questions have come up with what to do with newborns of COVID-positive moms. So I'm going to give you the information from the recently put out April 2nd guidelines from the AAP, and then the guidelines from the CDC. So here's what we know. We know that there are very low rates of peripartum transmission, and evidence is inconclusive about in utero transmission, but the vast majority of the evidence is that there is not in utero transmission and that there isn't an in utero symptom related to COVID-2. Newborns can acquire this virus after birth, and of course we know they have an immature immune system, so that raises concerns for severe disease, although honestly severe disease has very, 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 very rarely been reported. We are told to use airborne droplet and contact precautions when attending deliveries of women with proven COVID-19 disease, and probably that should apply if they're highly suspect. Now, why airborne? Because apparently during the second stage of labor, there's a lot of aerosols being generated as the mother is told to push and as she's told to breathe in a way that would generate an aerosol. So that's the rationale for that. When environments allow, newborns should be separated at birth from mothers with COVID-19. I think this is probably the one that's the most difficult because nobody likes to separate newborns from their mothers. And this actually gives you an out. So families who choose to have an infant room in should be educated on the potential risk to the newborn. Of course, since we don't know what that risk is, it's a little hard to educate them, but that is the recommendation. And I wish it were even a little looser, As you'll see, the CDC has a little looser stance on that, and they suggest that rooming in really is an option. We know that the virus has not been detected in breast milk, so we encourage mothers with COVID-19 disease to breastfeed their infants. If they can't do it directly, express the milk so that someone else can feed it to the baby. And then this one, infants should be tested at 24 hours of age. We don't want to test them before that because borrowing from the herpes simplex information, maybe they just have it on their body because we know the virus can be in the stool of the mom. And maybe that doesn't mean they're truly infected. Maybe they're just, transiently colonized. So we want to wait until 24 hours, and if they remain hospitalized, then do it again at 48 hours. My problem with this recommendation is we really don't know what to do with the results. So I hate doing tests where I don't know what to do with the results. The next recommendation is that newborns with documented infection or who remain at risk, and they remain at risk because you couldn't test them before, they require frequent outpatient follow-up by phone, telemedicine, or visits through 14 days after discharge. And I think that may be true for every baby. We would like them to have frequent follow-up. After discharge, the mother with COVID-19 is advised to stay 6 feet away from the newborn. But when she's closer, she should wear a mask until she's afebrile for 72 hours and at least 7 days have passed since her symptoms started. So that's that when can you stop the isolation. Mothers with COVID disease whose newborns require ongoing hospital care should not be able to visit. So they should remain separated until they've been afebrile for 72 hours without antipyretics and their respiratory symptoms are improved and they have negative test reports from at least 2 consecutive NP swab tests collected at least 24 hours apart. So those are the recommendations from the AAP. Now these are the CDC recommendations. And they start out with a paragraph about the many benefits of mother-infant skin-to-skin contact, and I certainly don't have to review that for this audience. They do state that risk of transmission to a baby is a concern, but they also state that the risk of infection after exposure and the clinical severity of illness are not clear. And that's despite having, a huge outbreak in China and huge outbreaks in Europe. So we still don't have a lot of information that neonates are at risk. So the CDC says that you should determine separation on a case-to-case basis using shared decision-making between the mother and the clinical team. And this is with mothers with proven COVID-19 disease. So they allow for this shared decision-making, which I like a little better than the AAP recommendations. And what considerations would you make? You want to know the clinical condition of the mother. Obviously, if she's severely ill, that's a different matter. You want to know the testing results of the mom. Is she just confirmed or suspected? And how about the infant? Were they confirmed or suspected? Does the mother desire to breastfeed? Is the facility capable of accommodating the separation or co-location? What's the ability of the family to maintain separation upon discharge? So it doesn't really make a lot of sense to separate the moms for 24 hours when they're going home to that house to be taken care of by that mom. In fact, since it's early discharge, you would really like them to bond with their baby and to get comfortable with breastfeeding. And then, of course, other risks and benefits of temporary separation. So the CDC goes on to say if a newborn is not separated, you should consider having physical barriers in the room like a curtain to keep the mom at least 6 feet away from the baby. And the mother should use a face mask and hand hygiene when she's breastfeeding. And if she's providing care, if she's the only one there or if there's not another person to provide care, then she should also use face mask and hand hygiene when changing diapers and comforting the baby, etc. And her face mask should remain in place the entire time she's providing care. If the newborn's separated, then you want to keep that baby separated from other newborns. They are considered a person under investigation. And who's ever taking care of that child, whether it's the staff or a parent, a non-maternal parent, they should use the proper protective equipment. And then you discontinue isolation in the same way that I mentioned before. So just a few notes about other preventive mechanisms. The CDC has put out travel notices. There's a global alert. This is a global pandemic notice that really you should avoid non-essential travel everywhere. And then for the first time ever, there's a domestic travel advisory put out for New York, New Jersey, and Connecticut. It was issued on March 28th, and it said that we shouldn't go anywhere for 14 days effective immediately. And I have not heard whether that's whether they've made it for longer than 14 days or not. This is the travel information. It's really a global disease, so you really shouldn't travel anywhere. And in fact, the Department of State issued a global global level 4 health advisory, which I've never heard of before, which basically says do not travel internationally, period. There are shelter-in-place proclamations for 42 states. 3 states have them in just part of their state, not the whole state. And then 5 states, the states in white, have not yet declared any sheltering in place. It's very important that we talk about physical distancing as opposed to social distancing. We really don't want people to become socially isolated. We know there's more mental health problems now, more suicides, more suicidal ideation. So we're really trying to call this physical distancing rather than social distancing. And that means staying 6 feet away. You really should measure this because 6 feet's a little further than you thought it was. There are vaccines in development and testing has actually started. And then everyone always should be hand washing, using cough hygiene, and staying home when you're sick. And these are the references for you. I went a little bit longer than I should have, but we do have some time for questions now. And again, we'll have questions next Monday.
Thank you so much, Dr. Fisher. That was a lot of really great information, and I anticipate that we will have a lot of questions. I already see quite a few coming in. Since there may be so many questions, we're going to try and manage the comments the best we can. I'm going to start with some of the questions in the comment box. So you can ask a question by typing it into the comment box on the right hand of your screen. If you're in the webinar room and you have a question that you would like to ask over the phone, please press the raise hand button at the top of your webinar screen, and we'll go ahead and call on you. After being called on, you'll just have to press #6 on your phone to unmute your phone line. If you are just dialed in by phone, you can just go ahead and press #6 and announce yourself before posing your question. So I'll go ahead and get started with some of the questions in the comment box. I see several questions about pregnant mothers. So Dr. Fisher, when pregnant mothers are not tested, should we be concerned about asymptomatic mothers at delivery and newborn protocols?
So that certainly is a concern of obstetricians, and I can tell you that our obstetricians are wearing N95 masks for pretty much every delivery. But remember, New Jersey is the second highest, but Pennsylvania's, you're getting up there. So I think that many people are concerned that pregnant women might be asymptomatically shedding, and we also have the concern that they don't always tell you if they're mildly symptomatic, or they don't always realize that they're having these mild symptoms. They just think it's part of the pregnancy. So sometimes they deliberately don't tell you because they're afraid you won't take care of them, and other times they just don't appreciate the symptoms. So we should be careful of all pregnant moms. That's in the labor room. That's not, when you go in to examine a baby with the mom, it's reasonable now to try to stay your 6 feet away from the mom, but I wouldn't be wearing face shields with every newborn exam.
So what about mothers who develop a fever during labor? Should they be considered PUI?
So again, that's certainly happening in areas where disease is most common. Most of those women are just going to turn out to have chorioamnionitis, and not, I shouldn't say that it's just going to have, because that's a bad disease, but many of them will just have a little bit of fever. So I think you do have to kind of individualize each and every case and try to figure out whether the mom has other symptoms besides fever, whether there's any contact, and really try to parse it out a little bit so you can really try to figure out which ones are which ones should be true persons under investigation, or which ones you're pretty comfortable either have chorioamnionitis or aspiration or some other reason for their fever.
Do you have any information on antibodies to COVID-19 in breast milk?
Interesting question. I have no information at all. One of the things that, you know, we've always said, oh, you have these great antibodies in breast milk. It turns out that for humans, they really aren't all that important because, in fact, the antibodies are degraded by stomach acid. So there's lots and lots of great stuff in breast milk, but the antibodies may not be the most important thing.
Mm-hmm. There's a question about surgical face masks for positive moms versus homemade masks once they're home with the baby.
So, so the homemade masks are anywhere from 50% blocking to about 80%. The surgical masks are about 80%. So it depends on the homemade masks. The ones that have filters are sometimes a little bit more effective, but also a little harder to wear, a little harder to breathe through. So all masks clearly are not equal. Remember, the main thing the mask is trying to do is just catch droplets. So they don't have to be perfect. So at home, a cloth mask would work just fine.
Great. And what is the risk of a fetus and a newborn? What is the risk to fetus and newborn?
So as far as the fetus, we haven't totally excluded in utero transmission, and there are a few case reports where you'll read that a baby had positive IgM, but the baby wasn't sick. So we don't think that this is a teratogenic infection. And in fact, you know, when you think about it, most respiratory viruses are not teratogenic. Of course, if it makes the mother sick enough, that may harm the fetus, but the virus is not thought, or is rarely thought, to get into the bloodstream, and we don't have clear evidence that it crosses the placenta or gets into amniotic fluid. Likewise, it's not clear that the virus is ever found in vaginal secretions. There are positive PCRs on stool, but whether that's pieces of virus or live virus, or whether the virus is still transmissible when it's in stool is unknown. So again, unfortunately, more unknowns than knowns.
Mm-hmm. I'm going to shift gears here a little bit to some other questions. So this is a question on aerosolizing on NP and throat cultures. Do you know if the data on this compares testing on adults, children, and children with sensory issues?
No, I'm not aware of anything specific, and I'll tell you, a lot of what I was talking about was anecdotal from kind of when I used to do pertussis studies and used to do those NP cultures. If it didn't make the patient cough, sputter, and whatever, then I felt as though I hadn't done a good job getting the specimen.
Mm-hmm. So I see here it says, we have prioritized 15-month-old and younger well visits and canceled older visits. Can you provide guidance on criteria we might be able to use to start seeing older well visits, like 2-year-olds, 4 to 5, 11, 16, vaccine visits initially?
I think what you're going to want to wait for is for the disease to have leveled off in your area, for you to get over that peak and start to see a decrease in disease. And then you're going to even wait a little bit. So I don't mind delaying those immunizations a bit. We just need to be keeping track of who we're not immunizing and who we need to get back. And then August is going to be I'm hoping that this is going to be over within the next couple months, and then August is just going to be crazy trying to get everybody immunized before school. But that's all right. We'll be so excited if we get to that point that we'll figure out how to deal.
So I have another question here. Could you talk about the taken temperatures in patients and staff as a measure of screening in outpatient practices? Would you recommend oral temperatures versus ear temperatures versus axillary temperatures if infrared
Sure.
thermometers are not available?
Yep. So I can tell you that what's done in my hospital are temporal temperatures on all the visitors and the staff who have been exposed. I happen to hate temporal thermometers. So if I had my choice, I would have people taking their temperature at home using either an electronic oral thermometer or a decent quality otic thermometer. And then the cutoff is either 100 or 100.4. For healthcare facilities, often people are using 100. I'm not sure why. For us, we've always used 100.4.
Do you think there is a GI route of transmission?
There definitely is GI disease. So we know that some patients have GI symptoms even before they get the respiratory symptoms, and we know that diarrhea is relatively common. We know that PCRs on stool can be positive. We just don't know how transmissible that might be. So we don't know if there's an oral, fecal-oral route. If there is, it certainly still is not the major route. The major route is still droplets.
Mm-hmm. What is your stance on physical distancing for all versus distancing for high-risk populations only?
We should all be physically distancing as much as practical. I mean, I don't think you can physically distance from your 2-year-old, 1-year-old, 3-year-old, but within your own household. But you can distance from your friends, 2-year-old, 3-year-old, 4-year-old. And I think you should.
All staff wear? Yeah. Should all staff wear masks and all who bring in children wear masks when possible? As CDC now says, we should all wear masks when we leave home.
So I'll give you the party line for this minute and tell you that it could change tomorrow. I was a little caught off guard when the CDC decided everybody now should wear masks. So I can't predict what the next statement might be. I can tell you that in healthcare facilities, the staff are wearing masks 24 hours a day, as long as we have masks that we can wear. The problem, of course, is getting the masks and keeping those supplies. But the best use of the mask is on a person who has symptoms to catch those droplets. So, just keep that in mind, what you're trying to do with the mask. If you're trying to protect yourself with just a mask, you're leaving your eyes open, and we know from studies with respiratory syncytial virus, people are always rubbing their eyes and picking their noses. So the mask covers your nose, but it doesn't do anything to keep your hands off your eyes.
So I do see some raised hands on the line. So Dr. Chavez-Nieto, if you could go ahead and press #6 on your phone line, that'll unmute you, and you can go ahead and ask Dr. Fisher your question.
Dr. Fisher, thank you so much for a wonderful presentation. I just want to clarify, I was asking about the screening of the temperature in the outpatient practices. So, based on what you said, it's preferable, your recommendation would be that people take their temperature at home. But if you want to start doing screening in the office, is it just enough to ask the staff and the patients, have you had any fever, have you taken your temperature at home, or would you recommend to take your temperature? And if so, that would be the best way if we don't have infrared thermometers.
Okay. Some of it was breaking up a little bit, but as I interpret your question, the question is, should staff and should your patients be taking their temperatures before they come to you, and what should they be using? So yes, I think right now that physicians and their office staff should take their temperatures at home and if their temperature is more than 100 degrees Fahrenheit, they should stay home and not come to work that day. As far as your patients go, the question would be, are you going to screen your patients and not see the ones that are febrile? I don't know that you're going to want to do that, but certainly you're going to want to separate the ones that are febrile from your well children. So the children that you're bringing in for immunizations and the parents of the newborns you're bringing in for well checks, those are the patients you want to screen with temperature, because you don't want the parent who's sick to bring their child to your office. So if the parent were febrile, then you would ask them to have someone else bring the child into the office.
And how about when entering the building? Would you recommend a screening when entering the building?
So some offices are doing that, or some clinics are doing that, that have someone stationed at the entrance of the building, and they're physically taking people's temperature before they let them into the building. In our hospital, we have a tent where you have to go to the tent and you're screened and your temperature is taken, and if you're a visitor and you have fever, you go home. You're not allowed in. If you're a patient, you get a mask, and then you're sent to the emergency department. If you're a woman in labor, you get screened, you get your temperature taken, get a mask, and you go to labor and delivery. So we are masking all of our men and all of their support people. If their support person has fever, we don't let them come in.
Thank you.
Sure.
Thank you, Dr. Shalvagneco. So we're past 9 o'clock, but we're just going to take a couple more questions because there's some really just important ones here. Dr. Coppola, I see that your hand is raised. If you're on the phone line, can you press #6 and go ahead and ask Dr. Fisher your question?
Yes, Dr. Fisher, thanks for the presentation. I'm having trouble with the ideal PPE protection that's laid out and the practical and the ideal. I mean, I've seen basically if you're seeing somebody with a respiratory illness, and we don't have a super high level in our area like you guys do, but of COVID-19. But if someone's coming in, you're recommended to have goggles, N95, gown, and gloves. We don't have that, and so we have none of that available, but we do have people with respiratory illnesses come in, so we're doing, I think what you have alluded to in the talk, not using the gown, basically, and using the goggles and the face mask, particularly if we have to culture somebody. And is it just fly by the seat of your pants, so to speak, and use things as best you can? I understand if you have masks and you let them dry for 5 days, you're probably safe, but that's also not a very practical way to use masks, unless maybe you have N95s, enough N95s to do that. I don't know if you can comment on the ideal versus practical.
Sure. I share your concerns that the ideal is far from practical, and that most offices do not have the PPE. So I think the first question you have to ask yourself is, how likely do you think the patient has COVID disease, and whether or not that patient really needs to be seen in your office or not? And don't forget to ask about the parents as well. So what PPE, if I have to kind of say which PPE is most important, it's masks first, and, surgical masks are not significantly worse than the N95, so I think a surgical mask is fine. Next is eye protection. Goggles are ideal. Face shields are okay if you can get them. I think it's probably, you may have an easier time getting goggles than the actual face shields. Both the goggles and the face shields can be reused. You simply wipe them down with a disinfectant. The masks, you can have extended use, but I don't know about everybody else, but I find them extremely uncomfortable after a very short period of time. So I think extended use is a tough one as well. The purpose of the gowns is simply to keep your clothes clean. So the gowns would be the last thing on my list to get. And the gloves, if you wash your hands, you actually don't need the gloves either. So those are my thoughts. And I meant to say something at the very beginning of the talk, along with my disclosures and disclaimers. Trudy was nice enough to mention that I'm your District 3 chair. Today I am speaking as a pediatric infectious disease doctor. I am not speaking on behalf of the AAP, and I forgot to get permission before I gave this talk. I'm actually supposed to do that. So don't take this as this is the AAP board's response to anything. This is Meg Fisher speaking as an infectious disease person, period.
I think it's more than period, Meg. You're amazing.
Thank you.
So we're going to do one last question. Do you think parents who are staying in the child's hospital room require PPE?
I do not, because they've been with the child at home, so I don't think they need PPE to protect them. However, we require them to wear a mask to protect us, because we figure if the child's infected, there's a good chance the parent's infected, because, you know, probably most of the time the parent gave it to the child, not the other way around. So, or the parent may be an asymptomatically infected person. So we do ask the parents to wear a mask when there's a healthcare provider in the room. But we don't require them to wear the mask after we go out of the room, because we think they've already had exposure from their children.
Okay, I think that will finish up the hour, a little more than that. I want to thank Meg for an amazing, fantastic presentation. I want to thank all the participants who hung in there with us. If you have a question that was not addressed today, remember we have a follow-up Q&A session on Monday the 13th from noon to 12:30, and there'll be emails coming out with the details of that. Also, if you have other questions in between that you want to look for an answer for, you can always send them to info@paaap.org, and we'll try to get those answers for you. To receive CME or CEU credits for today's webinar, complete the steps in the email that will be sent to you after this webinar is over, and then you can always contact us. Thank you so much, Meg. This was amazing. We really appreciate for the clear presentation that you gave. We'll send those slides out, and I want to thank everyone else that joined us tonight, and please have a safe few days. You can see some of the instructions on the presentation now, and please join us Monday for further conversation, and please stay safe out there. Thank you so much.
Thanks. You too.